Okay, I think it's time. Hi everyone, I'm Emma Troughton, Communications Manager for Mental Health Colorado. Thank you all so much for joining our virtual conference series on women's mental well-being. This free conference is offering 60-minute afternoon presentations and discussions from Tuesday through Friday this week. Experts by experience, advocates, sorry, I lost my spot. Experts by experience, advocates, practitioners, and others are addressing and discussing some of the unique mental health experiences faced by women and other people of marginalized genders. We are grateful to you for joining us today in acknowledgement that women's rights are a mental health matter. Yesterday, our presenters spoke about eating disorders, weight stigma, mental health treatment, equity, as well as vulnerability and brain health. Today, our presenters will talk about criminal justice and empowerment, in addition to perinatal well-being and environmental and social supports during pregnancy and postpartum. Tomorrow on Thursday, we'll hear about intimate partner violence prevention, about working moms and burnout, and about trauma recovery and resilience. And then finally, on Friday, we will hear about sexual assault prevention and perinatal violence prevention. Please invite your colleagues and allies to join us this week. And please know that each of this week's summits will be recorded and will be made available on our website indefinitely. Before we get started, I want to thank Dr. Jen Lieferman, Director and Founder of the Population Mental Health and Wellbeing Program at the Colorado School of Public Health, and Dr. Kim Gorgans, Professor of Psychophysiology, Clinical Neuropsychology, and Psychology of Criminal Behavior at University of Denver for their partnership in assembling our roster of experts for this week's series. I also want to thank my colleagues at Mental Health Colorado for all of their efforts in making this series possible. And thanks again to all of our presenters and participants for joining us. And please know that our advocacy and education work is possible thanks to the generosity of our partners and allies. So thank you for your donations. In this historical moment of persistent and emergent violence on women's rights and personhood, globally and domestically, from Iran to the US Supreme Court, we aim to promote more holistic comprehension of women's mental health needs in the interest of advancing well-being and empowerment, especially in anticipation of the midterm elections. If you haven't registered to vote, please do so without delay by following the link in the chat, and make sure that your voice is heard. As you listen to our speakers, you can use the Q&A function to ask any questions, and we will have a few minutes for questions after our final speaker of the day. With that, it's my great pleasure to introduce our first speaker before going off screen to listen attentively. We have Julie Keel, who is the Executive Director of the Empowerment Program, and she's joined us today to speak about criminal justice and empowerment. So thank you so much, Julie.
Thank you so much for having me. I'm so excited to be here.
Of course.
Yeah. I'm going to talk a little bit and then I'm going to pass it over to Mary Lucero Hill, who's a staff member at Empowerment. But just to start off, the Empowerment Program has been around since 1985. And it actually started in a very cool way with a group of volunteers going to the Denver Women's Correctional Facility to meet with women and elevate their voices and really get directly from those incarcerated and involved in the system, like what kind of services and supports would be helpful for you to get your needs met and get out of the criminal legal system and stay out of the system. And so from those voices and those ideas, was born the Empowerment Program. And so our mission is to holistically help individuals build healthier lives from the inside out. And we do that by providing a variety of mental health and wellness services and treatment and supports, peer specialist supports. A really, really big part of empowerment is that we really value employing individuals who have similar lived experiences as the participants. And so that's a little bit about empowerment. I have a super long history with empowerment myself. I worked as a care manager at Empowerment back from 2001 to 2006. Actually went to law school at night, left in 2006 to practice as a public defender for a bunch of years in both Pueblo and Jefferson counties. And that stayed connected with empowerment through those years, was on the board of directors, and then came back about 4 years ago. So we do a lot of the individuals we work with, not all, but a lot of them have current or former involvement in the criminal legal system. And specifically, we have a couple programs, one called Wages, which is work and gain employment and education skills, working with women who are on parole in Denver. And then we also just recently partnered with the city and county of Denver to help open a place called Project Elevate, which is a community corrections program for women in Denver. And we are trying very hard within, the confines of our criminal legal system, of course, but being as trauma informed and trauma responsive as possible, really transforming community corrections for individuals, providing gender responsive services. So it's really anyone who believes that they would best be served by gender responsive services designed for women is welcome. Because it's a community corrections facility, individuals are either sentenced there directly by the court or come from the Department of Corrections. So yeah, I wanted to touch on, I could talk about so many things. I'm trying to be mindful of the time because I could go on and on really, but a few things that I just want to make sure I say before passing this over to Mary is 100% of the women we work with, and really 100% of the women involved and individuals involved in our criminal legal system have experienced complex trauma, and most prior to incarceration, but all definitely during incarceration. And so, we need more hope. And like I said, like I just said with Project Elevate, we want to be part of the change. And we work for that every day. We really provide very individualized services when working with participants, but also want to be part of broader changes, within a lot of our systems, specifically one being the criminal legal system, because it's just my experience as a deputy public defender and representing children and adults, and a lot of what we do and what's done in that system is very shame-based and not trauma informed, not trauma responsive. And so it's really shameful, really, in my mind, to as systems pile additional trauma onto individuals who already have very complex histories of trauma. So we really at Empowerment focus on bringing back the humanity and remembering that every life has just as much value as the next. And, the saying, meeting people where they're at, we've been doing that literally and figuratively for a very long time in Empowerment. And just providing that hope and that connection and relationships. Relationships are so vital to healing. And strengths-based, no shaming, non-judgmental. Can you say more about individualized services? Yes. So, of course we do some assessments, although I could go on and on about how I feel about assessments right now, which is I don't really love them generally. I see the value. However, the individuals we work with, and like every individual in our criminal legal system, has been way overassessed. But when I say individualized, each participant definitely will do like a care plan of sorts, with very interactive with their care manager, peer specialist, whatever staff they're working with at Empowerment. And so it's created together and very individualized for the person. What one participant might have as a goal in their plan, maybe it often is very different than the next. So yeah, so that's what I mean. And really, I also, when I think of individualized, and when I say this like almost every day when at Empowerment, is we're all about equity, not equality. So what one individual might need to get their needs met or want, according to how, they want to live their healthiest, happiest life, very different from another person. So hope that answers that question. And I am going to pass it on to a couple more questions. Let's see. What are some persistent barriers to access housing, healthcare supports and services? So, there are quite a few, but the first ones that come to mind are like substance misuse, substance use disorder, which oftentimes, not always, but oftentimes started as a result of self-medicating, mental health issues. So we see a lot of barriers with people not only obtaining housing due to mental health and substance use disorder issues, but then also maintaining the housing. And criminal record couple, put that together with a criminal record, especially if there's a sex offense on that record, that's really difficult to find housing. Healthcare, we do a great job, I will say, of getting people connected with primary healthcare. But then again, if someone doesn't have stable, safe housing, it's very difficult to really maintain that connection again. So any other questions? I think I got all the questions. So I'm going to pass it over to Mary. She is a care manager at the Empowerment Program.
Hi, everybody. Thank you for having us. My name is Mary Lucero Hill. I'm care manager here at Empowerment Program. I've been here since March of this year, but I'm not new to case management. I have about 7-8 years of case management experience. My focus today is more on the mental health of loved ones, of like the mother, the sister, the spouse, the daughter, of those who are in incarcerated situations. So me personally, I've had loved ones along the gambit that have been incarcerated and have criminal histories, and then having to basically live a life on hold while they're doing their time as well. So I guess the old saying is you're doing time as well as they're doing time. For me, mental health wise, it was challenging to balance out my normal day life with my professional life, with my personal life, and how to kind of make it through each day with those types of challenges, working or living with loved ones who are going through the criminal justice system, because you are the one that they depend on, the one that they love the most, the one who's there for them. You sometimes end up being the lashing person, the person that they lash out on the most, and the person that they get angry with the most. So having all that trauma put onto you, all that vicarious trauma, it gets overwhelming, and it gets you start to think that that trauma is your trauma. And to just differentiate your life from theirs, you start to get too enmeshed. So one of the things that helped me was to go to therapy myself. But again, if you're the only one that's doing the therapeutic work, it's not really going to be as helpful as if the loved ones are doing it as well. So one of the really difficult parts that I encountered was the limited resources for mental health services for not only us as family members and loved ones, but for those who were incarcerated. So say Jenny comes out of incarceration for 5 to 10 years, and she's trying to find some type of mental health services. Well, it's very limited depending upon what kind of insurance she has as well. So if it's Medicaid, there's very little Medicaid options available, because those that are on Medicaid, there's waiting lists everywhere. If it's more private insurance, it does get a little bit easier, but having to be on a wait list once you get out and having to face all the issues of coming out of incarceration can sometimes lead to recidivism, going back to old ways. And that's never a good idea. One of the other things that I wanted to touch on was institutionalization. There's really no mental health services for women who are incarcerated, as well as family members who have loved ones who are incarcerated. And working with their loved ones on when they are institutionalized, how do you really talk with them? How do you connect? All those types of things. And there's none of that we have anymore. Prisons and jails are just boarding houses for mentally health individuals. So it's something that, we need to, as professionals, kind of work on with our state governments to get changed. That's kind of all I had in a nutshell. So I don't know if there's questions. I haven't seen any, but I will turn it over to Emma. Thank you again for having us.
Of course, thank you so much for sharing. And I think we will just keep moving through today. So next we'll have Jen Lieferman, and we'll do some Q&A afterwards. So thank you so much.
Great, thanks, Emma. And I think Adam was going to share my slides, so thank you, Adam, for that. Thank you for having me today. I am Dr. Jen Lieferman, and I am a professor at the School of Public Health. I chair the Department of Community and Behavioral Health and direct a Rocky Mountain Prevention Research Center. And one of my passions is really to better understand those factors that protect folks and really enhance well-being, especially during this perinatal period. So thinking pregnancy through the first year postpartum into interconception time as well. And we have a master's course at our school that focuses on training practitioners to think about how to develop programs and inform policy to, again, enhance well-being and hopefully prevent against mental illness and substance use disorders. And so a lot of that work actually has informed what I'm going to share today. And when we think about the perinatal period, and go ahead and next, please. We know that there's a high prevalence of depression and anxiety during this transition into parenthood for both moms and for dads. And many women in particular are left untreated or undertreated. And often this is due to a lot of different things, as we know on this call, but one of the big reasons is access to care, and that a lot of folks cannot access the appropriate care in an appropriate timing, which was mentioned by our earlier speakers. And so in our work with public health, we really try to think about what are some strategies that we could employ that would bring a meaningful change to a lot of people. So think of it as being like complementary to services at an individual level that are really tailored and there to provide treatment. We're thinking on the prevention side in hopes of keeping people well without needing treatment. So next slide, please. So we propose this conceptual model, and this is based on reviewing the literature, trying to identify what are those factors that we know by evidence promote well-being and protect against mental illness and substance use disorders that we can actually change or modify. So that's how we identified these. It is by no means exhaustive. It is just the beginning of trying to figure out what can we do to help this burden system of care that we're confronted with right now. Next slide. So I plan to just talk through this briefly and then share a few intervention strategies that our center has developed to help people promote their own well-being. So the first is at the personal level. And these are things that you can think about that are endogenous or within you, but that we can perhaps strengthen. So the research shows there's a connection with beliefs and things like spirituality, religiosity, feeling connected to some higher being or something greater than oneself. And that's correlated with enhanced well-being and has also been shown to reduce depressive and anxiety symptomatology. The second personal resource would be around coping. So how do folks actually cope? And boy, we just came off of this pandemic where we saw this increase in mental distress, and especially among our women in the perinatal period. And how were they coping with this amazing stressor that they were confronted with? And we find that there's particular coping styles that are really helpful. The first would be mindfulness. There's a lot of research out on mindfulness now, and it does really show a strong correlation with enhanced well-being and then a reduction in anxiety and depressive symptomatology. Another type of coping style that has been well researched is problem-based coping. So think about when you're confronted with a problem, being able to acknowledge it and then to address it, and thinking about problem-solving strategies. How can I confront the stressor and hopefully reduce the stress? The last piece on personal resources has to do with our behavior. So there's a lot of talk out there about self-care and health behaviors related to self-care that really promote well-being are behaviors such as physical activity. So we know getting regular, moderate intensity physical activity reduces depressive and anxiety symptomatology, and also promotes overall well-being, eating a healthy diet, and more recently, sleep hygiene. Having good sleep hygiene and good sleep quality has been really critical in enhancing mental and physical health, especially during the perinatal period where we're transitioning to parenthood and oftentimes sleep is compromised. Next slide, please. And so with this next slide, we talk about social resources like social support, social norms, and cultural consonance, And so when we think about that, we heard from Julie earlier, the social connection was really important. And social support, whether it's emotional, so like you're bonding with other folks, informational, you're actually learning things, appraisal, you are being supported by how you're doing, as well as instrumental, you have those tangible resources around you, like think transportation and resources. And so that connection and that peer-to-peer connection comes out very strongly in the research, and how important that is, whether women during the period get this from a partner or from some other close loved one, is very important, as well as having those connections to resources that they may need. And these resources could be things related to food insecurity or housing. And it could be even smaller things, just information related to prenatal care and what they should be doing to promote a healthy pregnancy and postpartum period. And then next, we find that this cultural consonance is really strongly coming out in the literature, and it refers to the degree to which individuals' behaviors and beliefs align with their shared cultural models. Think about like things in their lifestyle and their relationships and their family life. And that cultural identity or perception of cohesion and belonging to the cultural group increases an individual's ability to cope with stressful life events like pregnancy and postpartum. And that women in the perinatal period with strong cultural identity and cultural ties, they report lower scores on perinatal mood disorders, and they also report a higher sense of well-being. Sorry. And then as we move out to the next slide on community, we're kind of moving further away from just the individual itself, but thinking about the woman during the perinatal period and what are those resources in the community that can support her in her care. And we see that access to quality prenatal care, and prenatal care, really thinking about it broadly. So care for just as we conceptualize just broader prenatal care, but also linking to care for mental health needs, as well as other resources in the community that would help promote well-being. And a lot of those resonated in the first presentation. And also thinking about creative ways we've seen in the literature where the pathway for the access to these resources could be stronger by utilizing community health workers such as promotoras or doulas or other community-based leaders to again enhance that resource connection to the community. So you kind of have the connection happening at two levels. The first, the peer-to-peer model, especially with lived experience, is very powerful. And then the connection to the outer resources within the community, and perhaps going through an inherent already extant network base within the community to strengthen that access to care and resources. And the next piece on community has to do with your neighborhood. And we see in the literature that strong neighborhood integration and cohesion may decrease stress and promote positive coping and supportive community, social capital, access to resources. So really having that strong neighborhood cohesion integration shows to be protective. And the last piece is on this nature-based prescription. And what we see in US is a little bit further behind than what we're seeing over in Europe right now, but in other parts of the world. But nature-based prescription is very powerful. So folks just interfacing with green space, whether it's community gardening, forest bathing, any way that you can carve out your interaction with nature shows to be really protective on one's mental health and promoting well-being. Next. And so here at the School of Public Health, we have some resources that we have developed to think about how can we help folks promote their well-being. And we looked across all of the resources that we reviewed right in this model to think about what could people do at an individual level that they could do regardless of their resources, where they live, and to promote their well-being. And in our Rocky Mountain Prevention Research Center, we do quite a bit of work with communities in Colorado. This center is funded by the CDC and is designed to do community engaged work to promote physical health and mental health. And our center really focuses on well-being. And we were during the pandemic, we were working closely with these communities across Colorado, in particular, rural communities. And they kept saying, hey, we need to get something out to our folks, to help them during this time. But the folks who needed the most help really didn't have the time to come do like some extensive training to help protect them. And so we asked, how much time do you need? How much time do you think folks would give us to help try to make a change in their well-being on some of these strategies? And they said 5 minutes. And so we identified these 5 strategies here. It's called Pause for Your Well-being, with each letter within pause representing an actual item that, again, anyone can do wherever they're at, regardless of resources. And so think physical activity, because we know that is protective. Mindfulness is the second for awareness. The connection piece is just coming out so loud and clear, like we need to connect folks to one another and to nature and to their communities, build that social capital. S is for sleep. Getting enough sleep really improves your well-being and your mood, and as well as your physical health. And then the last one is a little bit newer to folks, and it's expressing gratitude. And the literature is really showing to be very strong in this space that individuals with higher levels of gratitude, they report overall, enhanced well-being and higher levels of happiness. And there's simple strategies that can, folks can use that can help improve their well-being. So those videos are free and they're accessible, and I have the link there for folks if you want to utilize them. And I think in there at least about 5 minutes for presentations or questions, not presentations.
Thank you. That was great. I'm checking the Q&A function. I'm not seeing any questions here. We might be able to circle back after the third presentation if we get any more questions in the chat.
Okay. Thanks, Anna.
Yeah, thank you. So I'll go ahead and introduce our third presenter, Charlotte Farewell, who will be speaking about perinatal social supports. Thank you.
Wonderful. Thank you so much, Emma. Let me just here to pull up my screen. All right. Thank you so much for having me. I'm so happy to be here. And my name is Charlotte Farewell. I'm an assistant professor in the Department of Community Behavioral Health with the Rocky Mountain Prevention Research Center. So I do work closely with Dr. Jen Leiferman, who you just heard from. And I'm going to be building off some of the things that she touched on. I'm going to kind of jump around over a couple slides, so not to be repetitive, but really go more in depth about how we can think of these external resources and supports that we know are particularly protective with respect to perinatal mental health and well-being. And so just, briefly, Jen mentioned this, but we know that perinatal mood disorders are a significant problem in our country and globally. And for example, recent data suggests that about 1 in 5 pregnant individuals experience depression and similar rates in the postpartum period. This is through 1 year postpartum. And we know that anxiety rates are similarly elevated. And in fact, due to COVID over the past 2 or 3 years, anxiety rates, perinatal anxiety, have exceeded those of depression. So we know that there's a real need to identify further supports and resources to bolster well-being during these critical transitional periods. And there's fairly extensive data, as I'm sure most of you are aware on this call, of risk factors that are associated with poor perinatal mental health. So we know that maternal depression and anxiety tend to co-occur with other adversities, including many of the risk factors that you see on this slide. And you can see, touching on what Jen's presentation was focused on, really that many of these factors are occurring at multiple levels. So for example, the individual level, things like trauma experience, ACE exposure, socioeconomic status, of course, and then thinking about kind of these external resources such as lack of social supports that we know can also contribute to poor perinatal mental health. But the real focus of this presentation, much of the work that both Jen and I do with the Rocky Mountain Prevention Research Center, is to take a more strengths-based approach to exploring and intervening on protective factors that can promote perinatal mental health and well-being. And to do this, one of the frameworks that I think is really valuable for us to think about is this salutogenesis framework. So this model was developed by Aaron Antonovsky back in the late 70s, and it's a stress resource-oriented concept. So it's focused on resources and how we can promote, maintain, improve health and well-being, instead of thinking just about how we can mitigate poor mental health. So the model stipulates this continuum that goes from health ease to health disease. And you can see the visual here on the right that shows that traditionally, oftentimes, and especially in the psychological field, we think about symptoms of mental illness. So we think about depression, panic disorder, anxiety. But on the other end of the continuum and spectrum are these symptoms of mental health. And so we think about emotional, psychological, and social well-being. And I think this is a really valuable framework for us to consider as we think about perinatal mental health and well-being specifically, because it argues that folks are on this continuum. So we don't see someone as mentally ill or mentally healthy. It's a constant continuum, and there's opportunity to improve our mental health and well-being over time. It also empowers the individual to see their health in this way and recognize that there are opportunities for them to cultivate their well-being. So it is a proactive approach. And for example, the first slide, we talked about 20% or so of perinatal individuals experience depression. Well, that means 80% don't. And so what is creating health and well-being for those individuals who aren't experiencing perinatal mood disorders, even though they may be exposed to the same structural stressors or stressful life experiences, which we'll talk a little bit about. So all of the work we do is really framed with this approach. And I'm not going to go over this because Jen just mentioned the model she shared is very similar to this, but really everything that we do, and I think resources in general, when we think about perinatal well-being, it's necessary to identify these multi-level factors instead of just focusing on one level of influence. And this really connects into this idea of the resource capacity model, or the conservation of resources theory, which is actually a theory developed from an evolutionary theory. So it really gets at adaptation and posits that we as individuals seek to obtain, retain, and protect resources across the lifespan, and that stress occurs when these resources are threatened or lost. So as we know, with respect to the perinatal period, there is a lot of resource loss that happens around birth, childbirth, the postpartum period, and oftentimes that can lead to these poor mental health outcomes. So by really focusing on cultivating both resource reservoirs, so accumulating as many resources as possible during pregnancy, and then continuing to promote these resources across the perinatal period and beyond, we can help form these resource caravans. And these resource caravans data suggests that these caravans are really what can be most protective. We know that many protective factors and resources co-occur together. And so by targeting through intervention, through policy change, multiple resources across these critical periods, literature suggests and we hypothesize that these might be the most effective approaches to really promoting well-being during this very important critical period. And so I'm just going to spend just a bit of time, a few minutes here, going more in depth about some of the social and environmental resources that we target with our work and that the literature suggests are most protective with respect to perinatal mental health and well-being. And again, really focusing on what we can modify. So we recognize there are these structural constraints, but what really can be modified to help buffer some of the negative health outcomes associated with the lack of structural resources. And so when we think first about social networks and social supports, as Jen alluded to, we know there's extensive data that suggests they're strongly related to overall mental health and well-being, particularly during the perinatal period. The challenge here is that these pathways are really complex. So there's not a definitive pathway that says, by increasing this type of social support during pregnancy, we will see X or Y outcome. So there's a lot of different mediators and moderators that are playing a role here. Also, social supports and social networks can be protective in different ways for different individuals. So you can see these bi-directional arrows in this model really highlights the kind of convoluted relationships that exist between thinking about our social supports, but then also how that impacts individual coping resources and personal resources that Jen mentioned, as well as kind of the organizational and community level or environmental level resources. But we do know that social support is important and is protective for perinatal mental health. And specifically, the literature with respect to perinatal mental health suggests that maternal perceptions of strong social support, so even just the perceptions, are really important. And they're associated with better mental health, essentially, increased parenting warmth, and increased parenting self-efficacy. And there are a couple sort of caveats to that. So one of the hypotheses that has been playing out in the literature is this optimal matching support hypothesis, which suggests that the type of support must match the need. So I'll expand in a moment on types of support, but we know that there's not just a one type of support that works well, again, for every individual. And so there's three or four kind of different types of social support, and it really depends on what that individual, what that community is in need of at the time, which can be the most protective with respect to their mental health during pregnancy. And then we also know that the types of supports that are most beneficial may vary by source, which I'll mention in a moment, as well as sensitive period. And so this is a area of research that we spend a lot of time thinking about, and there's a lot going on right now in the research field related to sensitive periods, but thinking about the experience of pregnancy versus early postpartum versus late postpartum, and acknowledging those are all very different experiences, and therefore different resources may be most protective during those time periods, instead of just, social support being protective, specific types of social support being protective across the entire period. And so the types of social support that we think about and that we know can be protective are these three that you see on the slide, and Jen mentioned these, but emotional support, instrumental support, and informational support. So having, on the emotional side, having close friends and family members provide hope, thinking about instrumental support, having parents watch children while the parent can run errands, or on the informational support side of things, a doctor providing information about postpartum depression. So all three of those are important types of social support with respect to perinatal well-being. But when we think about sources of social support, there's some variability here in the literature. So we can think about sources of social support as being informal versus formal. And we've found, and the literature suggests, that informal social supports are particularly protective during these critical periods. So a recent 2021 systematic review actually synthesized the literature on informal social supports and found that partner support was actually the most protective. So having a strong partner above and beyond family, friend, any other types of informal or formal support. And this was protective during pregnancy and the postpartum period. It's important to note there's some bidirectionality here, which requires some additional work to think about, if you remember the bidirectional arrows in the model, but we know individuals with less informal supports are tend to be struggling more with their mental health. And when you're struggling with your mental health, you tend to isolate and have less informal social supports. So it's important to really further explore the bidirectionality there. But regardless, we know that partner support is really critical. And a similar systematic review that was done in 2019 also found that actually when they're looking at family and friend support, they found that friend support actually wasn't significantly protective with respect to perinatal mood disorders. So family support was above and beyond. So there may be a few different hypotheses related to this, but one is that family members are more likely to be directly involved in the caregiving role, which may be particularly protective when we think about mental health in the postpartum period, for example. And then in terms of formal social supports, this can take sort of many different platforms or organizations can deliver formal social supports, but this includes government, community groups, formal social organizations that are developed to support pregnant individuals and postpartum individuals. And so we know that peer support groups are particularly important and protective. Provider relationships and trust is key also to fostering access to care and mental health care and prenatal care. And then there's a lot of work being done around integrative collaborative care recently, identifying the importance of integrating mental and behavioral health services into obstetric settings to ensure that pregnant individuals have access to a holistic range of healthcare rather than just prenatal care that may just be focused on their physical health. And then the last thing I'll comment about social supports is that there is this spillover effect, and this gets back to the conservation of resources theory, but we know by targeting one type of support that tends to spill over to additional supports. So it can be this sort of snowball effect of promoting resources. And then the other kind of level of supports or resources that I'll just mention relates to social capital. So social capital is really the degree to which residents throughout a community are connected with one another. So building just off the interpersonal or social support level, now thinking about this broader community or neighborhood level, and both bonding connection within networks as well as bridging connection outside of networks have been found to be protective with respect to perinatal mental health. And then both cognitive and structural components of social capital are protective. So thinking about perceptions, again, of the quality of social relationships, so things like trust, as well as the structural components, so the quantity and quality of social relationships throughout an individual's network. And this model shows the links between low social capital and common mental disorders. And again, you can see that this is a similarly complex issue because there are a lot of different pathways that have been hypothesized that link social capital and mental health. So there's a lot of work going on right now looking at both these individual pathways as well as more of the community level pathways that you can see outlined in this slide. I won't spend time going through them, but I do want to highlight just some of the most recent literature in this space. So one of the largest studies that has looked at social capital, and specifically social capital as it compares to human capital, was a study done by Richard Rose, and it was about 20 years ago now, but I think still relevant because he looked at human capital defined by things like education, socioeconomic status, so household income, and then he looked at social capital, as we were just discussing, among a large group of individuals or pregnant individuals. And he basically found that human capital accounted for about 12% of the variance in emotional health, while social capital actually accounted for almost 16%. So it just highlights that, there are these structural concerns that absolutely need to be addressed and social determinants of health that are so important to think about. And we also have the opportunity to buffer some of those exposures when we think about perinatal mental health through the cultivation of social capital. So that's a really interesting finding. And specifically among low resource populations, which is a lot of the work that we do at the center are focused on lower resource populations, both domestically and globally, we can see that these protective factors are really, can really buffer the effects. So higher social capital has been found to buffer associations between stressful life events and maternal distress across the postpartum period. And these are all findings from large longitudinal studies. So we're talking at least 5,000-6,000 pregnant individuals. Community belonging specifically has been associated with decreased depression across the perinatal period. And this study, our team did actually internationally, but looked at community belonging from pregnancy through 54 months postpartum and found it was one of the most significant factors with respect to promoting mental health. And then higher reported neighborhood social cohesion has been found to be associated with better mental health in the perinatal period. And these findings, one of the biggest studies is from the Fragile Family Studies, which oversampled low resource populations. So collectively, these findings really highlight the implications of this work, highlight the need, building off of what Jen presented, but highlight the need to really think about multi-level supports to promote perinatal mental health and well-being. And some of the key resources that may be most protective are the informal role of partners and family. So including partners and families in these more formal prenatal programs and prenatal care may be critical to not only building resource reservoirs during pregnancy, but then encouraging resource caravans that are sustained over time. So targeting these multi-level supports. And then the final piece that the literature suggests is really extension and integration of these services over multiple critical periods. So oftentimes we just think about pregnancy and we prioritize and promote resources during pregnancy. And a lot of studies suggest that that isn't enough because we know, again, this transition can be very difficult into the postpartum period into parenting. And so really extending services, both formal and informal services for individuals, for parents through even the second year after birth, some studies suggest is really the most effective and most cost-effective way to promote perinatal mental health and well-being. So I'll just end with this final slide. This is a summary of personal, social, and environmental resources that should be targeted for perinatal mental health and well-being interventions. This was a study done by Kelly and their team just a few years ago, but I think they really synthesized the literature and identified the resources at this point in time that were most evidence-based in the literature. So I think it aligns with a lot of things we've been talking about and really highlights, again, both the personal, social, and environmental resources that need to be considered in perinatal programming from a preventative point of view to think about, to target in order to, again, kind of cultivate perinatal mental health and well-being over a long period of time, recognizing that trickles down to the intergenerational transmission of resiliency. So thank you so much, and I'll stop sharing.
Thank you so much. That was great. I was wondering, I had a question come through my chat feature. And I'm wondering if you or Dr. Leiferman can speak to the potential role or the current role of peers in supporting perinatal mental health.
Yeah, I think I'll let Jen, I don't know if you want to speak a little bit about My Baby, My Move, but Jen is the current intervention that really utilizes peer supports to facilitate prevention programming during pregnancy. So she may be best to speak to.
Okay, thanks, Charlotte. Yeah, we do. We just finished our last trial on the My Baby, My Move community intervention. We've tested it now like 4 times, and we're hoping to roll it out on a much larger scale. But most recently it was funded by NIH, and basically what it does is we work closely with communities. We identify women from the community who have had a pregnancy in the past, were active during that pregnancy, and really embrace this kind of, wellness and trying to enhance well-being. And we train these women from the community to deliver this community-based intervention that before COVID we were doing in recreation centers within that community. And during COVID, we had to pivot to do it online, so we can do it in both formats. But basically, the peer leaders meet with pregnant women during their pregnancy at the recreation center in their community. And we train them, we have a whole curriculum, how to really embrace these self-care behaviors that we talked about, much of what we've talked about. And then they not only teach them these things, but then they actually do mindfulness yoga, and they do walking. And so we try to do skill building. But I think, after all of the feedback from the program, women just really enjoy being connected to other women and learning from other women. And it definitely has had a significant impact on their pregnancies. And then we hear about how it's helped them in the postpartum to continue their self-care. It's just one example of something that's happening here in Denver.
Cool. Thank you so much for speaking to that question. And thank you to all of our presenters who have joined us here today, and to all of the participants who have joined us. I think we'll go ahead and wrap up here. And I want to remind everyone who's on this call that we will be continuing sessions throughout the remainder of the week. And tomorrow is Thursday. So tomorrow and Friday, both of those sessions will be at 2:00 p.m. Mountain Time as opposed to 3. So please do note that. And then also there will be recordings of every session available on the webpage, which I will upload retroactively. So later this week, you can find those there. And I think that's it. Let me check the Q&A real quick. Sounds good. Cool. Thanks, everyone. See you tomorrow.